change happening in critical care medicine. We'll be digging into excerpts from a paper called Less is More, a critical care paradigm shift.
It's about understanding how doctors are, well, rethinking the care for the most seriously ill patients.
And this shift, you were saying, it's pretty dramatic compared to how things used to be done.
Oh, definitely. When you look back at the history, it's almost, a complete U-turn in some ways.
Okay, let's get into that history then. To really get a feel for this change, we probably need that context. So, the first ICU, where did it start? Copenhagen, right?
That's right, Copenhagen, 1953. During the big polio epidemic there, it was an anesthesiologist, Bjorn Ibsen, who got it going.
And the first patient wasn't even polio, is that right? I read that somewhere.
Correct. It was a 43-year-old man who'd attempted suicide. He needed a tracheotomy and basically someone to breathe for him manually. Quite a start.
Wow. So that unit, born out of a crisis, that was the beginning.
That was the seed, yeah. And then things developed. By 1958, you started seeing the first ICUs staffed by physicians popping up in the U.S.
Ah, okay.
Yeah.
People like Max Harry Weil and Herbert Shubin.
Exactly, in L.A.
Yeah.
And Peter Safar over in Baltimore. That was when it was really recognized that these incredibly sick patients needed, dedicated specialized care.
And then came a big technological leap in the 70s.
Yes, the pulmonary artery catheter, the PDC,
Yeah.
developed by Swan and his colleagues.
And that became foundational.
Absolutely. For about 4 decades, it was the monitoring tool in critical care, almost iconic.
And its arrival, you mentioned, sort of ushered in a certain mindset.
It really did. It cemented this very proactive interventionist philosophy. The thinking was basically, if some care is good, then surely more care must be even better.
Lots of measuring, lots of doing.
Precisely. A very hands-on, aggressive approach to managing these very fragile patients.
Which makes this current shift we're talking about so interesting, because as this paper highlights, almost everything we do in medicine, procedures, tests, drugs, ventilation, it all carries risks.
Especially in the ICU. These patients are so vulnerable, and the risk of complications from the care itself, iatrogenic complications, it's significant.
So the big question we're diving into today is, what happens when that whole philosophy flips? When more is better starts to look more like less is more?
That's the crux of it. And interestingly, the questioning really started gathering steam by looking hard at the very symbol of that more is better era, the PASIC.
The pulmonary artery catheter again.
Yeah. Around 1996, studies started popping up asking, is this thing actually safe? Is it even helping patients get better?
And the answers weren't what people expected.
Not entirely. The research that followed began to show that, well, the detailed numbers the PASIC gave, sometimes they were actually misleading.
Misleading. How so?
Leading doctors towards treatments that, well, weren't actually beneficial. And the bottom line from multiple studies was, using the PACE didn't improve patient outcomes, didn't help people survive.
That's huge for something so central for so long.
It really is. And the consequence, the PACE is now, pretty much gone from routine practice, almost abandoned.
A powerful lesson in reassessing our tools.
Definitely. You have to be willing to change course when the evidence points that way, even if it's challenging established practice.
And it wasn't just the PACE that triggered this rethinking, right? You mentioned the ARDSNet study in 2000. The paper calls it a landmark for less is more.
Absolutely. A pivotal study. It looked at patients with ARDS, acute respiratory distress syndrome, a severe type of lung injury.
Okay.
And it compared 2 different ways of using the breathing machine, specifically focusing on the volume of air per breath, the tidal volume.
Right. And what did they find?
They found something quite remarkable. Using a lower tidal volume, 6 milliliters per kilogram of ideal body weight resulted in significantly better outcomes. Fewer deaths, actually.
Compared to the old standard.
Compared to the standard at the time, which was about double that, 12 milliliters per kilogram, it showed that being gentler on the lungs, inflating them less with each breath, was actually much better for these injured lungs.
Like not overstretching a damaged balloon.
Exactly like that. It was a clear demonstration that less intervention, less aggressive ventilation could be more beneficial.
So ARDSNet really helped crystallize this less is more idea. What are the core principles, then, of this newer paradigm?
Well, fundamentally, it's about being gentler, less invasive. It's about recognizing that our powerful tools can also cause harm, unintended consequences.
So more selective intervention.
Yes, exactly. The focus shifts towards supporting the body's natural healing processes and really trying hard to minimize those iatrogenic complications we talked about. Less focus on just doing things.
And the paper lists specific examples where less seems to work better. We touched on lower tidal volumes. What about plateau pressures? Is that related?
Very related. It's also about lung protection. Plateau pressure is the pressure in the lungs at the end of an inhalation. Keeping that lower also helps prevent ventilator-induced lung injury, so lower volumes and lower pressures.
Got it. Okay, next on the list, less blood, being more restrictive with transfusions.
That's right. Historically, we might have transfused patients when their hemoglobin dropped below a certain relatively high level. But research now suggests that for many critically ill patients, waiting until the hemoglobin is lower before transfusing is just as safe and maybe even better. It avoids the risks that come with transfusions, reactions, inflammation, and so on.
Okay. And then less invasive hemodynamic monitoring. That ties back to the PAC story.
It does.
Yeah.
With the decline of the PSC, the trend is towards using methods that are less invasive or even non-invasive to keep track of heart function and circulation.
Like what?
More reliance on the physical exam, careful blood pressure monitoring, sometimes using ultrasound or other less invasive devices to estimate things like cardiac output, basically using the simplest, safest method that gives you the information you need.
Right. Now, less fluids. This one feels a bit counterintuitive. Don't sick people need lots of fluids?
That's the common thought, isn't it? And yes, adequate hydration is crucial. But we've learned that flooding patients with intravenous fluids, especially early on, can actually be harmful.
How so?
It can lead to fluid overload, worsen swelling, make lung problems worse, potentially impair organ function. So the approach now is often more balanced, more cautious with fluids, sometimes called fluid stewardship.
Interesting. Okay, moving on. Less insulin and less intensive glycemic control. So not trying to keep blood sugar super tight.
Correct. There was a period where very tight blood sugar control was advocated based on some early studies.
Right, I remember hearing about that.
But larger trials showed that aiming for that very tight control significantly increased the risk of hypoglycemia, dangerously low blood sugar.
Which is bad in itself.
Very bad. And it didn't consistently show a clear survival benefit to outweigh that risk. So now, for most ICU patients, the target range for blood sugar is more moderate, safer, generally.
Makes sense. Next, less antibiotics. Specifically, de-escalation and shorter courses. How does that work?
Well, when a patient comes in very sick and we suspect a bad infection, we often have to start antibiotics quickly before we know exactly what bacteria we're dealing with. So we might start with broad-spectrum drugs that cover many possibilities.
Okay, the empiric therapy.
Exactly. But the key is, once the lab cultures come back and tell us the specific bug and what it's sensitive to, we should narrow the antibiotics down, target the treatment. That's de-escalation.
Ah.
And alongside that, research has shown that for many infections, shorter courses of antibiotics work just as well as the traditional longer courses. This helps reduce side effects and, crucially, slows the development of antibiotic resistance.
A really important point. Okay, less sedation and less benzodiazepines. I always pictured ICUs as places where patients were kept pretty deeply sedated.
That certainly used to be more common. But we now realize that keeping patients heavily sedated for long periods has significant downsides.
Like what?
Higher risk of delirium, that state of confusion and agitation, spending more time on the ventilator, longer stays in the ICU and hospital overall.
So the approach now is lighter sedation.
Lighter sedation whenever possible, using strategies like daily sedation vacations, briefly stopping the sedation to see how the patient does, and trying to avoid benzodiazepines if possible, as they're particularly linked to delirium. The goal is to have patients more awake and interactive sooner.
Okay, what about less corticosteroids? The paper mentions a specific dose, 200 milligram hydrocortisone daily, for sepsis and COPD.
Yeah, this is quite specific. In severe sepsis or septic shock, studies suggest that low-dose hydrocortisone can help stabilize blood pressure and might offer a survival benefit for some.
And for COPD flare-ups.
For acute exacerbations of COPD, a short course of systemic steroids is standard practice to reduce airway inflammation. But the key word in both cases is less.